Hello, Dr. Khanna.
Yeah, we are all set for your talk.
Hello, ladies and gentlemen. I would like to thank again Dr. Khanna and Dr. Henry for this kind invitation. It's a great honor to be here again in the APVS. We are going to have a talk about the application of stem cell therapy in vascular disease. This is my group where we study here here in Brazil. I have no disclosure except that this is an issue, is a topic that we are dealing with several years. We are publishing some articles in this in order to fight ischemia, gangrenes, and diabetic foot. And we ended up writing a book regarding stem cell therapy for vascular disease. And we are going to talk here is a summary of the first chapter of my book, the introduction to stem cell therapy. Why study this issue? Because despite medical and scientific advances, vascular disease continues to challenge us, remaining the leading cause of death and morbidity in our modern society. However, understanding the biology of such stem cells was a tremendous advance in our modern medicine. But initially, we have a very strong limitation because stem cells were derived from embryonic cells. So to study embryonic cells in humans were unethical, so we could not advance in that. It was limited, so we could not translate into clinical therapy. However, in 1962, John Gurdon, studying frogs, he had the idea to replace the nucleus of an eggshell of frog, of course an immature nucleus, for a mature nucleus from intestinal cells of the same frogs. And what happened? It happened that that eggshell eventually turned again into a new frog, a complete new frog. So he concluded that the DNA of mature cells had all the information needed to develop all cells in the organism. So in the year 2006, two Japanese researchers, Yamanaka and Takahashi, were able to identify in a murine model genes that kept cells immature in their embryonical state. And by activating those cells, he was able to transform a differentiate cells into a pluripotent cells. The next year, in 2007, they were able to do the same in human cells. So, not surprisingly, in the year 2012, they were awarded with the Nobel Prize for Medicine and Physiology. There is some confusion regarding the terms: stem cell, stromal cell, mesenchymal stem cells. So we are going to define them. Here, the definition of stem cells is the population of cells that are capable of self-renewal and differentiation capabilities. The stromal cells are those cells with secretory, immunomodulatory, and homing capacities. And finally, mesenchymal stem cells are the populations of cells that are regenerative cells derived from the mesenchyma. But nowadays, we are able to interchange all these terms. So no matter if you say mesenchymal stem cells, stromal cell, or stem cells, they are the same for practical purposes. And what are the types of stem cells available? Of course, most of our adult cells are capable of differentiated into another type of cells. So we're gonna study several adult types of cells derived from the bone marrow, from adipose tissue, and from the peripheral blood. The bone marrow was the first and the most studied stem cells type. It is harvested by the bone marrow aspiration, but in there we have heterogeneous populations of cells contaminated by other types of non-regenerative cells. So we have to apply some methods like centrifugation, washing, and seeding on culture dishes in order to acquire a much better number, a higher population of stem cells. The same applies to the adipose-derived stem cells. But the difference is that the adipose tissue is very disposable. So what we do, we perform a lipoaspiration, easily accessed, but we also will have a heterogenic population, but we will be able to filter a very small fraction that we call the stromal vascular fraction that contains adipose-derived stem cells, pericytes, endothelial cells, pre-adipocytes, and immune cells as well. In order to identify the stromovasculars and isolate the stromovascular fraction, we need to wash, to agitate and centrifugate, and sometimes to digest that amount of lipoaspirated. And finally, the peripheral blood-derived mesenchymal stem cells are very disposable once the blood is easily disposable, but there are very few number of stem cells in the blood. So we need to stimulate some sort of inducing the stem cells, like the granulocyte colony stimulation factor that we must previously inject to the patient in order to induce a population of such cells to be available at the peripheral blood. Of course, the treatment and the studies with this peripheral blood is very expensive because of that. Of course, we have also other sources, but clinically they are there's only a few numbers of studies, and they are irrelevant in the clinical scenario. So, what's the mechanism of the treatment of the stem cell therapy? The first one is the cells differentiation into the cells that are needed in that area, which means tissue replacement. And the second is through paracrine effects, because the cells are able to produce cytokines, growth factors, and chemokines. That leads to angiogenesis, immunomodulation, neuroregeneration, production of extracellular matrix, and is able to reduce cell apoptosis and fibrosis. Regarding immunomodulation, this paracrine effects inhibit the type 1 macrophage pro-inflammatory into inducing a type 2 macrophage anti-inflammatory. And the same happens to the lymphocytes, inducing a shift from the pro-inflammatory Th1 to a Th2 anti-inflammatory subtypes, and also suppress the natural killer cell activity. Regarding immunomodulation, there is another issue that that there is a procoagulant activity, and also increases this complement activation, but it was reported, of course, some adverse thrombotic events, in some studies. So the general goal of the stem cell therapy is to restore blood flow to the ischemic tissue and to improve perfusion and function of that ischemic organ or tissue. These are the goals of the vascular, the cell therapy for our vascular disease. So what is happening in the clinical scenario? So our group performed a meta-analysis regarding the treatment of diabetic foot ulcers with autologous stem cells. And it was found that stem cell therapy was safe. It helped diabetic ulcer into healing and without any increased risk. So we had still many questions regarding what's the best type of cell? Its origin. What's the best administration route? And, it's good with revascularization, in association with revascularization. So we went through another systematic review, and what we found? We found that regarding stem cell types, the most used in the literature, in preclinical and also in clinical studies, was bone marrow. Bone marrow had more than 50% of the studies that they used bone marrow. A small part used adipose tissue, and another part umbilical cord. Only a small part used peripheral blood. So the best administration route was local, which means direct injection of the stem cells into the ischemic tissue or organ. And regarding origin, the vast majority, almost 90%, was autologous, which means derived from the patient itself. And it was good in association with revascularization. It was able to improve ABI, TCPO2, and wound healing with a lower restenosis recurrence and a longer amputation-free survival. However, all these clinical studies were very heterogeneous. There were different types of diseases in patients. The origin of the stem cells were very different. The isolation method is not yet completely standardized, and the administration routes are very different. So we perform our own study that we call the Limb Rescue Project, in which we use adipose adult cells with local administration, which means direct into the ischemic limb, with autologous origin, which means from the patient, and we filter the stromal vascular fraction in patients with unable to revascularize due to chronic limb-threatening ischemia. This is a phase 1/2 trial to assess the safety and efficacy of the stromal vascular fraction in such patients. But we are now conducting 2 extra branches One is in association with revascularization, one group with stem cells and the other with not going to stem cells, and directly into the wounds. So, but we are limited. We have several limitations in the therapy. Once our patients are aged, they have heart disease, they have renal failure, they have COPD, they are dysfunctional, they have neurologic impairment in use of multiple medications with extensive medical history. So the result is that we have a lower cell yield with regenerative potential. So in conclusion, ladies and gentlemen, stem cell therapy results in cytokines production leading to angiogenesis and immunomodulation that boosts wound healing. The current evidence shows that stem cell therapy seems to have good results in human patients. Adult autologous stem cell is the most common type of stem cell used in clinical practice. However, there is no consensus regarding the optimal time or type of cells, its origin, and the best delivery route. So its efficacy remains to be determined. Thank you very much for your attention. I am at your disposal for.
Thank you, Dr. Tulio. That was indeed wonderful. We'll have the questions after Dr. Gupta's talk. Just, I'm very impressed by your series. We have been doing stem cells for a long time, but we always go for autologous stem cell implantation. And our strategy is a little different. Like half of the stem cells we are going to give locally into the muscles. Other half, if we can get a catheter really down into the collateralizing vessels, we actually try to give it there through a catheter. But I do not know, we are still evaluating our patients. We do not have a proper steady design, but we have been doing it initially since long time. And anecdotally, I can tell our patients do fine with this therapy, but I don't know whether giving intra-arterially along with the local is beneficial or has an extra benefit, or it's only the local delivery which helps.